Brilliant, thank you. Good evening, everybody, and welcome to this Anglo-Israeli Association event in conversation with Professor Ran Balicer. My name is Richard Sloggett. I am the founder and Programme Director of the Future Health Policy Research Centre here in London. I'm a visiting fellow at the Policy Exchange think tank, and between 2018 and 2019, I was the Special Advisor to the UK Health Secretary. In case you're not familiar with the Anglo-Israeli Association, I'm sure many people are, the AIA was established in 1949 and is an independent educational charity that enjoys the active support of people of different faiths and people across the political spectrum. And we are delighted tonight to welcome our special guest, Professor Balicer. Professor Balicer is a public health physician, manager and researcher who serves as the Director of Health Policy Planning for the Clalit, which is Israel's largest healthcare organization. He is responsible for strategic planning and the development of innovative organization-wide interventions for improving healthcare quality, reducing disparities, and increasing effectiveness and care integration, including the introduction of novel data-driven tools into practice. He has medical degrees from Tel Aviv and Negev universities. He's authored many books, book chapters, and over 150 peer-reviewed publications. He is very much on the front line of the COVID-19 response in Israel. And he's going to speak to us tonight on exactly that topic, COVID-19, vaccines, and what I think we all want, getting out the other side. So without further ado, I'd very much like to offer Professor Balicer our warmest introductions and ask him to take us through some slides. If you would like to ask questions, please do post them in the chat, and I will try and get through as many of those following the presentation before we close later tonight. Professor Balicer, over to you.
Thank you kindly, Richard. Dear guests, it is a pleasure and a privilege to be speaking with you today. And what we will try to do in the time that we have, I will try to kind of brief you through some of the challenges and solutions that we see here in Israel in terms of dealing with the crisis at hand. And it is definitely a crisis that is we are very far from being out of the woods yet, despite all of the great achievements that have been achieved in the last 6 weeks or so. And I will try to explain why. And then some of our plans of finding a path out of this very dire condition. So indeed, with no further ado, I will go to the presentation. Thank you for the kind introduction, Richard. It was very kind. Let's see, screen, let me know. Do you see the slides? Do you see an opening slides, a blue slide?
Yes, I do, yes.
Okay, good, wonderful. So my name is Ran. I'm a physician by training and also an epidemiologist and public health specialist. And indeed, my day jobs is at Clalit, where I serve as Chief Innovation Officer and as the founding director of the Clalit Research Institute. And my night job is the chairman of the Israeli expert advisory team to the government on COVID-19 response. That does not leave much of the night for any other activity. So I will try to really, let's see. What we're going to talk about today really is really the COVID-19. And the whole story is here in this slide in front of you. It tells the Israeli story in one clear picture. Okay, so like in many other countries, this is the death curve, which follows the morbidity curve in about 2 to 3 weeks, as in every other country. But it's very clear. It shows the first wave on February, March, which we have controlled in a fierce and complete lockdown, one in which you saw wild animals in the streets, and people were really staying at home to the extent possible. And the effect of that specific lockdown was quite astonishing. Disease went down to almost nil within a matter of weeks, at which point the Israeli government had the most severe error in the entire running of this campaign. There was a mystical feeling that we have somehow overcome this illness, that we know how to deal with it. And the message that was given to the public was, you know, we're done with this. Go ahead, enjoy yourselves. We've had such a difficult time at the lockdown. Now it's time to have fun. Go drink beer, enjoy life, which we did. And for a while, it went quite well. And then we now know what happens at that point, right? So COVID has begun in the up slope that you see here during June. And as the rates went up, we have made more serious attempts to create settings that are more, I would say, COVID relevant. So restaurants were to a great extent halted, and some of the mass activities, weddings, etc., were put in under some kind of control. And it was the time of the Jewish year where many of the festive activities were out of the picture. Nothing to do with COVID, just the time of the year. And all of that together has brought a standstill in the continuous upslopes. And for a while, again, we thought we had things under control. And then came the second wave and the second lockdown. It was exceedingly effective. I mean, people did not really lock themselves at home like the first lockdown, but it was quite effective. R went down to 0.7, 0.65, which means a dramatic exponential decline in cases, and following that in the deaths that you see on this slide, at which point we knew that, you know, if we don't get things under control, it's only a matter of time. But since the point in which we reached and where they've started reopening the economy was too high in terms of the rate of morbidity, again, you know, COVID did what it always does. At which point they tried different types of lockdowns, and then we went to the third lockdown. The third lockdown took place at a point in which the B117, the UK strain, was perhaps 10% of the new cases. And that's where the lockdown has begun. And we are currently at a point in which we are exiting the third lockdown, and we do so in an unprecedented rates of morbidity in R that equals 1, basically. So we didn't see the massive decline that we hoped to see despite the lockdown, and I will talk about the reasons to that soon. And we are trying to calculate what is done next. So how come we are exiting a lockdown with R equals 1 and thousands, 8,000, 7,000 cases per day? That's going to be the discussion that we'll hold today. So in order to understand what's happening, maybe it's worthwhile to explain where I'm coming from. Most of you, or some of you might be familiar with the Israeli healthcare system. So we need to overall care for 9 million citizens, and there's universal health coverage. Everybody is insured by law. They don't need to pay for their services. They get it through a government-funded a wide basket of services that is given for free through 4 sick funds. And the largest one of these 4 sick funds that are insurer-provider systems that are both the insurers and the provider of primary and secondary care. The largest one of these 4 is called Clalit, and 52% of the Israeli population are members of Clalit. And Clalit provides all of their care needs and a wide set of services given for free: GP services, specialist services, hospital services, imaging, pharmacies, anything you wish is in one centralized organization, all under one roof. Community care, hospital care, inpatient, outpatient. And the Clalit clinics are throughout the country from north to south. This will be very relevant when we'll talk about the vaccines. So it's important to the discussion here. And Clalit is the only organization in Israel, only one of the 4 sick funds that actually has its own chain of general hospitals, with about 1/3 of the acute hospital beds in Israel that reside in Clalit. And Clalit is the forerunner in digital health, with a lot of focus on disease prevention and a leader in innovation in practice. This will be quite relevant, as we'll see in a second. So the nice thing about the Israeli healthcare system, that's been fully digital for over 20 years. So electronic medical records, ubiquitous over 20 years. All the data flows into central data warehouses, where each one of these organizations, each one of these sick funds, holds its own cache of health data of its members and uses it in order to provide improved care to the people that they care for. So Clalit in specific is going through a decade-long transformation where it's trying to move from what we see here on the left, which is the classical provision of care, working in silos, being equal instead of equitable, working in silos instead of providing integrated, coordinated care, focus on reactive therapeutics instead of preventive, proactive care, and all of the other classic modalities of the old paradigm. And what we have been quickly moving is to the right-hand paradigm here, trying to do everything as directed as possible to make this shift. And the key to this transition, especially from flying blind to providing value-driven care, is basically data. And we have abundance of data that's available to us, probably one of the largest data sets in the world, and we use it to give proactive care. So for instance, if we want to prevent dialysis and kidney problems, we go ahead and we do predictive modeling through AI algorithms that identify the patients that will have dialysis 5 years from now. And we approach them today through our physicians and through apps and through different modalities, trying to get them to come to early preventive care so we can prevent them from getting dialysis in years from now. When we do it in a point in which it's both not costly and not painful to provide this treatment and this approach. So this is really important to understand, because when COVID-19 has hit us, we had the same kind of notion, and we said, what do we need to do now? Well, we need to do what we always do. What do we always do? We use our data in order to identify populations at risk and do proactive outreach to these populations to do something meaningful. So what we've done very early on in March, in the first wave, we have collected all the data we could from the world and from our own database, and we created a predictive model that was able to identify which patients would deteriorate to severe COVID. And regardless, taking age into consideration, but also younger people with high risk. And we create what is called the risk point model, in which people did their own calculation. They had their own kind of manual how to do this, and you calculate the number of points that you have. And according to your age, you knew which risk strata you were in and what you were supposed to do. And our physicians called all of the patients in the highest risk strata and have told them, dear Mr. X and X, you are at high risk. Please do not leave your home to go to, for instance, to get care. We'll get care to your house. We'll provide you either digital care, online, telemedicine, or we will get a team coming to your house. Don't get infected. And so this had a tremendous impact. And you can see how we improved from wave to wave. And by the second wave, the people that were at the highest risk group were already reduced to only 3% of those infected, as compared to 5% and even more at the beginning of the first wave. So the percentage of the highest risk group within the infected has continuously dropped. And that really made an impact on our fatality rates, on our case fatality rates. And when you look at case fatality rates in Israel, you can actually see, here's a comparison to just 3 other benchmark countries. You can see here the UK, Germany, and United States. I'm not comparing any time in the distant past, because then the differences were much, much, much more marked. The case fatality rates were very high in different countries. I think it might have also been associated with the kind of care that was provided in the hospitals, and as well as to the testing policy and who got tested. So when we look at the current state of affairs since November 2020, you can see case fatality rates. And so part of it is age groups within the country. Israel is slightly younger than the US, but far younger than Germany. And so this also needs to be taken into account. But again, one of the lowest case fatalities in the world in general have been witnessed in Israel. So some of this predictive proactive care was pretty helpful. And so if you want to put the mortality, this mortality graph, if you want to have it in proportion as compared to other countries, despite the fact that Israel has the highest infection rates than almost any other country, the mortality rates are still, even at the highest peak that we have, lower than many of our comparison countries. It has to do, again, with age groups, but also with all of these measures that we've talked about. So, into vaccinations. we have made a strategic decision that vaccines would be our key out of the crisis. And very, very early on, once vaccines became available, Israel had been able to secure a good set of advanced purchase agreements with different manufacturers. So we hedged our bets on different manufacturers. We supported Moderna fairly early on, before they were actually too well known. And we were one of the first countries to have a contract with them, as well with other companies as well. Bottom line is that we eventually had a good a number of vaccines provided by Pfizer, and the vast majority of the vaccines provided to date in Israel are Pfizer-BioNTech vaccines. And what we see here is the picture from 2.5 weeks ago, from January 25. And what do we see here? This looks great, right? It looks like, look at the numbers. I mean, these are the people that got a dose, at least one dose. And you can see here, above the age of 60, you can see 70%. Above the age of 70, it's already reaching 90%. Fantastic. At that point in time, people wanted to get out of the lockdown. And we said, nope, not good enough. And why is that? This graph will tell you. Because at that point in time, what we had was that only 22% of our population above the age of 60 were vaccinated and protected. And full protection means 7 days after the second dose. So we said, no, as the panel of experts, we said too early. We know that, our lockdown is not as effective as we wanted. And we know that we can't continue like this forever with an R of 1 and the entire economy being completely shut down. But it's too early, because if we release it now, people will get infected before they have full protection, and they will pay a dear price. And this is, by waiting just a little longer, we can make a huge difference. And that was the decision that was made. And indeed, this was the group that we put our eye on, the 51% at that point, which were only partially immunized, that did not have yet reached the second point. We said, just wait a week and a half, and you'll see where we're standing by that time. And indeed, 3 days ago, when the decision was brought again, we said, okay, this is time. So what do we see here now? Now we see that the 60 to 69 have moved from 70 to almost 80. That's not such a great difference, right? That doesn't seem like much. So what's the big fuss? But the real thing lies, by the way, look at the numbers. Overall, until now, 5.6 million doses given in a country, I remind you, of 9 million people. 5.6 million doses provided, 3.5 million Israelis that have received their first dose. And about a third of the population cannot be vaccinated, because you cannot vaccinate below the age of 16. So that also needs to be taken into account. So 3.5 million Israelis got the first dose, 2 million already had their second dose. So and a massive amount of these, as you can see, is above the age of 50. So this is where we are at. So we said, now we open. Why? Not because of this graph, because of this one. Because at this point, the partially immunized are only 9%, and the fully protected are 72%. We said, okay, that's it. It's not going to get much better than this. If we want to experiment on a safe exit of the lockdown, this is the time. We get as much of a protection as we can. And this is the point in which we are now experimenting on opening a lockdown in a horrible setting in terms of our hospitals are packed with severe cases still, because mainly, I'll explain in a second, the number of daily cases is still too high. Still, we open up because we can't continue like this. There's pandemic fatigue and pandemic frustration that will not allow us to continue for long, but also because we have what at least a direct protection, and I hope soon some indirect protection that the vaccines can provide us. And at this point, we should be able to see this effect being ensued more and more as time goes by. So the decision was made. Now, why hasn't this third lockdown worked as well as the previous ones? Two key reasons. One is because people did not adhere to the recommendations as much as they did before. And the real reason is B117, aka the UK strain, which is an exceedingly infective, but also probably slightly riskier and more virulent strain that is a very problematic virus. So, so how do we do it? How do we get so many people vaccinated so quickly within 6 weeks? That number. I will skim through a set of potential explanations to that, and I'll be happy to entertain questions afterwards on more details about each one of these. First one, Israel is young, fairly young, and very geographically condensed country. This is the fact of the matter. And by being geographically condensed, it gives us a lot of opportunities to provide the logistical aspects much easier than in many other countries. So this is point number one. 1 second. The second point that I want to talk about is the distribution chain. And again, we've had a really effective distribution chain that was run by the government from the airplane to the big freezers that are required for the Pfizer vaccines. And from that point on to the vaccination clinic directly. So being small country helped us to get just this two-stage approach. And vaccination clinics were operated fully by the HMOs, by the 4 sick funds that, as I said, are very integrated, strong, logistically, and in terms of workforce, and used to outreach campaigns and giving the annual flu vaccines to a large proportion of the population. We knew how to get it done. And so this was really key. The fourth thing worthwhile mentioning is digital health. And again, the HMOs are digital for decades. And all of the, very quickly, all of them had their apps that have allowed us to do scheduling through an app to your vaccination clinic and online, reminders on the second dose. And we combined this digital approach from not just high tech, but also high touch. So we had a lot of low tech call centers calling the 70 years old and older, those that were not digitally connected. And we had some solutions for ultra-Orthodox that don't have smartphones. And we had solutions for them in order to get them into the vaccination clinics. So that was quite helpful. Next point I want to mention is that, despite the fact that we could do really granular indications and prioritization schemes for those to get vaccinated, we didn't select to do that. And we said we're going to go simple, as simple as we can. First tier is 60 plus and healthcare workers. That's it. As simple as that. So everybody would know. They don't need to make any complex thing. We don't need active remind. This everybody can take responsibility, and indeed worked very well in making things simple for the public to know when to come. But while having a prioritization scheme, we also had a lot of operational agility, which means we wanted as low as possible attrition rate of the vaccines, fewest destructions that we can, because you open a vial, you get it out of the freezer, that's it. You need to use it or lose it. And so we had sites in which, you get to the end of the day, there's leftovers. So, nurses go outside and say, hey, anybody, pizza guy, do you want to come get vaccinated? I don't care that you're 21, come in. We had, social media notifications that said in this place, at this hour, there's extra vaccines. Come, hoard in, and get your vaccines. So that happened in parallel. So, we had less than 0.1% of the doses being actually destroyed, which is pretty good for such a fastidiously sensitive vaccine. Last 2 points. To get people vaccinated, you need to persuade them that all of the fake news and all of the disinformation and misinformation out there on social media is bogus. So what we did was several things. One is transparency. We told things as they are. When we didn't know, we said we don't know. When we said, there's not enough follow-up, we said we don't have enough follow-up, so we don't know the answer to this question. However, we think that because the risk from the disease is very clear and because these theoretical risks have not been shown anywhere, the right decision to take is this and that. And that's why we start with the high-risk groups, because, we don't have follow-up time. So at this point, the benefit-risk ratio goes for this group most evidently towards get vaccinated. And it works. Transparency works. Also leading by example. So all of the relevant leaders got vaccinated in front of a camera to show that we practice what we preach. I got vaccinated live. It all started with the Prime Minister and the Minister of Health getting vaccinated live. That helps. Lastly, to get the message in and get people to worry less about the vaccines, we had a very big effort on culturally adapted messaging and outreach. So we went to the communities and spoke with community leaders in order to persuade them, and through that get to the different communities. For instance, I went to a rabbinical kind of a lesson that is done on a weekly basis with all of the ultra-Orthodox physicians, and spoke with the person in charge, which is a very, very notable cleric, rabbinical leader. And after 2.5 hours, they have grilled me with scientific questions that went to the bits and bytes of whatever it said in every page of every scientific publication. At the end of that, that person said, you know what, I'm convinced vaccines are safe enough and effective enough and important enough for me to give a rabbinical verdict that says, go ahead and get vaccinated, which he did after a few days. And, just a short time later, all of the chief rabbinical leaders in the country that have not been sick by then went on and got vaccinated. And that had a huge surge of getting the ultra-Orthodox community vaccinated. And until today, they're doing much, much better because of that. These are kind of, in a nutshell, some of the aspects that allowed us to get to where we are. Future is misty. It's really difficult to say where we are. There's a race. There's the virus, the UK variant that is threatening to continue dissemination. Our hospitals are still filled up with severe cases, and we are still suffering badly. And we are opening up, which might increase the burden. On the other hand, we do have an astonishing achievement in vaccinating the vast majority of our at-risk population that really, really should, within a short amount of time, begin to see a drop in the overall number of severe cases and some loosening of the burden on our hospitals. And as we vaccinate more and more, we will also begin to see the indirect effects of the vaccination campaign, which means not herd immunity, because that's far, far ahead in the future, but some indirect effect and some epidemiological barrier that would reduce the R and the number of daily infections and allow us to open more and more parts of our economy. Also, by using what is called the green passport, the fact that you were vaccinated in 7 days after your second vaccine gives you, in our suggested plan for opening up, some privileges, and there will be an opening of cultural events and retail opportunities that will be dependent on showing that you have this green passport. So this will allow us new types of opening schemes that will allow us to go to some type of normalcy with a dramatically reduced risk. So again, I think that we will be one of the first countries to be able to employ this, and everybody else would probably be watching to see what does it take in order to confront an unprecedented level of infection and dissemination in the community setting with a vaccination campaign. With that, I will stop and entertain any questions.
That's brilliant, Professor Balicer. Thank you so much. That was fascinating, and thank you very much indeed for sharing those slides as a structure. It was really, really helpful. We've had 3 or 4 questions come in on the Q&A, which I'll go to, and I've got some myself that I'd also like to ask. We've got in the UK, we've got a big concern at the moment about the South African variant of the virus, and we've bought a lot of the AstraZeneca Oxford vaccine, and some recent data seems to indicate that vaccine is slightly less effective against this new variant. How much of that is a concern to you in Israel? You mentioned the UK variant, but how much concern are you about the South African variant and the AZ vaccine?
So the South African variant is of worry because it has additional types of mutations that do not exist in most of the circulating UK variant strains, although it is catching up some of these extra mutations in some places. So yes, we are worried about this variant, and we have been isolating it in Israel, but very sporadically. It hasn't really disseminated too widely. So it is not a big problem yet, but it might become one. We are still hopeful that the Pfizer vaccine would prove as effective to the South African variant as it does to the UK variant. There's some preliminary evidence that might be the case, and there are some very early evidence that doubt that. So the jury is still out, but no doubt a potential for an escape mutant to at some point, partial escape mutant to a variant. To emerge is something that we put in our contingency plans, and when that will come, that will be a wild card that will change everything once again. But for now, we have the current troubles to worry before we start worrying about all of the other things that can go wrong.
And on the question of who you vaccinate in what order, in the UK, we've had an age-based system. There's been a lot of discussion as we start to expand our rollout about the role of healthcare workers and teachers and frontline shopkeeping staff, about whether those sorts of people should move ahead of people rather than just using age as a mechanism to do the vaccination. Now, in your remarks, you talked about operational agility. How much have you stuck to the age-based approach, and what sort of debate was there in Israel about moving off an age-based model to more of a different type of risk-based model?
It's pretty straightforward. We at the beginning it was fully age-based, 60 years and older and healthcare workers, then 50 years and older and healthcare workers, then 50 years and older, and we allowed education staff to come and get vaccinated even if they were younger. That was one unique exception. And fairly quickly afterwards, 40 years and older, until we are now in a point in which all ages served. As long as they come in, we now go through the entire population and try to canvass and to vaccinate whomever comes in, with a great effort now to complement and finish the work in getting to the last 300,000 people above the age of 50 that have not yet been vaccinated and remain a source of potential severe morbidity in the coming weeks. So we do a really focused effort on getting them one by one. And we have a huge effort working on getting those people who are bedridden. They're difficult because you can't move the vaccines to them. You need to get them to the vaccine. At the beginning, we vaccinated their household members in order to protect them indirectly. Now we actually have specialized ambulances coming to their homes, getting them, putting them at the vaccination clinic, vaccinating them there and putting them back home. With all of this difficulty, we've been able to get about 60 to 70% of the bedridden patients already vaccinated. So it's quite an endeavor, but we're taking it forward.
Great. And on the issue, you mentioned the challenges around anti-vax and some of the sort of social media challenges. You said your strategy there was around transparency. I wondered if you could just elaborate on who some of these groups were and how you sort of challenged some of the misconceptions.
Look, the challenge is on. I mean, it's not something they talk about in past tense. It's very much in present and future tense. It's a problem. It is a problem these very days. It is a problem. We have the vaccines, we have the logistics capacity, and there's a slowing of the flux of vaccinated people. And this slowdown is a problem. And so we need to do more than we do, and we need to improve what we're doing. But what we've done, again, was to go ahead with the vast blanket bombing of messaging the public on, getting public figures that either got vaccinated live or that are trustful in terms of saying things as they are. And the messages were not just saying, don't worry, it's fine. It's don't worry, it's safe. Just go ahead and get the vaccine. That does not spark much confidence mainly because it's not true. So that's probably not the way you should move forward. You should say, we know X, Y, and Z. We don't know X, Y, and Z. And still, because of these reasons, we suggest you get vaccinated and you vaccinate your family members. That is helpful. Be transparent. You just say, don't believe all of those people. It's fully safe. Just go ahead and get vaccinated. That doesn't work. People don't buy into that.
There's some great questions coming in on the chat, and please do keep them coming in. One that's popped up quite a few times, and you can imagine this, You talked about green passports within Israel. One of the things we're having a debate in the UK about is whether we should have a vaccine passport, particularly for travel. Do you see having a vaccination being a requirement to travel between the UK and Israel in the coming months? Is that something that you think is going to be inevitable?
It's really hard to tell. For now, Israel has declared full closure of all of its air travel, land travel, all stopped. In the recent weeks, since the new variants became more prevalent out there, Israel has made a strategic decision to try and become an island, a real island, in practical terms, and halt all travel whatsoever. And this is still the case right now. It's only private planes with very specific authorizations get to land here, and people can't leave or come in because we worry. And some of these worries will not be fully alleviated by being vaccinated, because we know that no vaccine is going to be 100% effective against getting infected, even if not with a severe disease, and potentially bringing new strains into a country. And a negative test that was taken several days before air travel does not completely negate that option as well. So at some point there will be kind of a weighing of the consequences and the risks, and I guess some kind of an arrangement will be made. I guess many countries that are deliberating on the same question will have to decide together as part of the IHR, the International Health Regulation, and some of the bilateral treaties between countries on how this will work. We have not yet made a decision on this, and will take a while before we do this, I imagine.
That's excellent. And on the issue of the vaccines themselves, there's a question here about, do you feel that there'll be sort of an annual sort of vaccination program, a bit like, boosters for flu, different flu variants? Do you see that becoming a sort of part of normal life?
Absolutely. Yes, first of all, it's boosters, because I think that we will need more boosters, because I don't know how long the immunity will be conferred for. And because we need a high titer of antibodies to tackle some of the new strains, and so boosters will be important. But also, what's nice about RNA vaccines is that you can replace you can change them fairly easily in terms of the process, test them, and get them in to the market. And so I do see, just like the vaccine for influenza that is modified yearly according to the antigenic drifts that do occur on a yearly basis, we will see either a new strain, if you'd like, a new mRNA sequence that would be given on a yearly basis, or biannually, or whatever will be decided. It could also be a mix, more than one strain in a single shot, so you can be fully protected.
And specific questions coming on the Pfizer vaccine itself about how effective just the first shot is and when it reaches maximum effectiveness, and in the absence of the second shot delayed to 12 weeks. It's a debate we've had in the UK around doing the 1 dose versus the two. I'm not sure if you're able to elaborate on that.
Only to some extent. So we probably have the richest data set to be able to answer that question. And we are conducting a very careful methodological assessment of this question with the best available methodologists working on the data. The thing is that to do a real world setting retrospective assessment of vaccine effectiveness, taking into account lots and lots of biases and confounding effects that happen in real life. I'll give you just one example. In Israel, the most vaccinated localities are those with least dissemination of the disease. Just so happens to be. And it also has an inverse relation with socioeconomic class. So poorest localities, highest dissemination of the virus, lowest uptake of the vaccine. So if you just do a simple comparison and say, let's compare vaccinated to unvaccinated, you will reach all kinds of conclusions that may not necessarily be causally associated. So you need to be really careful about how you make inferences from real world data, which we are. And we are doing this in a very, very careful, very careful way. And I think we have the way to do a proper comparison. And once we go through the proper process of peer review, we will be able to share our conclusions with the world, but not before.
Excellent. And Barbara's asked a question on you mentioned a sort of 2.5-hour conversation with the rabbis. Now forgive my ignorance on this, but she's asked were the rabbis only interested in the kashrut issues or other issues?
It had nothing to do with kosher, non-kosher. It was really medical, scientific risk-benefit ratios. It was all about elucidating the risks and quantifying them, elucidating the benefits and quantifying them, and carefully weighing them one against the other to make sure that when they recommend to the people who follow their advice to do A or B, they're doing the right thing the right way.
It's very, very clear. And Laura's asked about some of the coverage we're getting in the UK around the Israeli vaccination program. And she says there's a bit of negative coverage around about the vaccination program not covering the West Bank. She says, though Israel may not be legally obliged to provide this service, do you think that they ought to morally start vaccinating there?
We as the national advisory team, we advise to provide vaccines to the West Bank and Gaza for a multitude of reasons. And I think from fairly early on, they have. At the beginning, if I understand correctly, there wasn't a willingness to take some of these offered vaccines. At some point, they did, I think, take some amount of that. But again, I'm not dealing with this directly. This is more something done in the Ministry of Health, and I do not have accurate information to provide on this topic. But epidemiologically, morally, whatever, I am definitely for that.
And just a couple of questions from my side. One on the UK is hosting the G7 this year, Professor Balicer, and I wanted to ask you what you'd like to see on that G7 agenda from a healthcare perspective. What do you think in terms of looking ahead to the future the UK should be championing in terms of the response to the pandemic and future pandemic preparedness? What do you think we should be focused on?
Well, interesting. I'd say, first of all, before we talk about the next pandemic, we have the previous one to recover from. So even in the best vaccinated countries, there's so much residual damage, collateral damage that this pandemic has caused. I'm not talking just about long COVID. I'm talking about all of the deferred appointments, all of the chronic care that was delayed, all of the mental burden that is inferred on the population, both by the fear of the disease, but also by the impact of lockdowns and inability to return to normalcy, the impact on our youth and the days they've lost school and the mental impact of being closed at home and all of the domestic issues that come with it. I can continue on and on. It will take us years to recover and to fully restore the public health to where it's been once, assuming the threat of this virus will be already far long gone. So I think that's one main issue that asks, how do we recover as nations? And how do we recover as interconnected nations where if one is not safe, all are not safe? And we know nobody can keep their sky or seas closed for too long. Eventually it will open, and it brings, again, there's a lot of interdependence, and so all of this will need to be discussed. In terms of future preparedness, our healthcare systems were the rate limiting step for recovery for many countries, and so we need to think about what should be done in order to create a more resilient and more surge capacity to our health systems to be able to withstand difficult surges. What can be done and how much does it make sense to invest in these emergency time capacity? Again, I think that there's a lot of issues that have to do with vaccinations and vaccine factories and our investment in new technologies that will allow us to confront the next pandemic, which will surely come. Pandemics are a reoccurring phenomenon and have been so for all of the recent centuries. And we've had 3 flu pandemics in the previous century. We had an aborted pandemic of flu just a decade ago. And there's still looming threats all around. So yes, I think that all of these would be worthwhile to discuss.
And you mentioned, and as is well known, Israel has a very strong digital health system. How important do you think that infrastructure has been for you to so quickly start to roll out your vaccine program and make it such a success so far?
I think it had a huge impact because, first of all, by the fact that every person is accounted for. We have his or her record. We know who's the GP that's responsible for them, who can contact them by name and address, and be able to, and has a trust relationship already there. By the fact that they are used to these types of ongoing vaccination campaigns on a yearly basis that also occur fully digitally, by the fact that we can calculate your risk score behind the scenes. And we know, we had what we call the coronometer, which was whenever you contacted the health system, the physician or the system, we knew what was your a priori risk of contracting COVID according to where you live and your age group and your past, all kinds of past data with a really intricate machine learning algorithms that were working in the background, and a lot of other things. And finally, the fact that we can do now really advanced assessment of vaccine effectiveness and side effects and everything else that we will release once all of this is done, I think none of this would be possible without the digital infrastructure.
And the final question for tonight is, how do you think this pandemic is going to change healthcare systems? You talked a little bit about resilience, we've talked about digital. How do you see healthcare systems adapting and changing? There's a huge backlog of care, there's wider population health needs of mental health. How do you see healthcare systems adapting and changing and trying to meet that need as we move forward?
So I think, and I will end really with a positive thought. The pandemic was the biggest digital accelerator in our time. And physicians and patients that weren't even thinking or considering of using digital telemedicine and advanced types, I mean, they had to adapt immediately, and suddenly barriers that were there for decades were dropped in an instance. Telecare became just care, because that's how you provide care when you cannot come in person. And suddenly, if care can happen, and for years we were told you cannot do this and this by telecare, it's too risky. If you don't see the patient, if you don't put a hand on the abdomen and it's too risky. But suddenly, the mother of all inventions is a dire need, and suddenly everybody adapted. Older physicians, younger physicians, older patients, younger patients, everybody now know how to use digital health. And when you have that, suddenly you can add on semi-automatic and fully automatic tools that come with that. And so I think that the vision that I've shown in my slides about the digital transformation of healthcare and the redesign of healthcare is something that is going to be vastly accelerated because of this. And I think that will do many good things to health quality, to access, and to equity at the very end.
That is a very, very positive note on which to finish, and it's an excellent note on which to finish. Professor Balicer, thank you so much for joining us tonight. It's been absolutely fascinating to hear from you. We wish you, I'm sure I speak for everyone on this call, we wish you every success in your continuing efforts in Israel, and thank you so much for taking time out of your schedule to come and present to us.
Thank you all. Godspeed.
Thank you very much.
Keep healthy, keep safe.
You too. Bye-bye.